if we are. Sir, we are live now. Yeah.
So, good evening, postgraduates. So, welcome to the I2I online version. We had a plan of having a physical meeting on 13, 14, 15, but for many reasons, not have it. And also, there has been a mounting pressure on all of us to have an online version so that more and more people can actually join without having the trouble of. But we can have a wider reach and also have the similar thing, exactly what we were planning for, and stretch it over, and so here we start from today. Today, myself and Dr. G for the anchors of this program, give you some kind of a warm-up session where we'll just again recapitulate. Some of you must have attended the I2I part 1, happened in the beginning of this year,
Yes.
where we did discuss about the how to present the cases, how to answer the violence. Now we will have a small recapitulation of the same thing for today. And from tomorrow, we'll have the actual mock case presentation of two normal cases as well as on fundus case, so that the students who are chosen to actually present the cases will be presenting just like in the I2I, physical I2I. We can have a discussion, but we can have a threadbare discussion of how to actually miss the exam without having to fear it. Same time to get all the tips and tricks of the examination that are needed for an exam going student. So you may be a very good student in the last 3 years. You might have really kind of pumped up the whole ophthalmology, but exam is something that unnerves everyone because we have been conditioned to fear the exam since childhood. Always been now very focused on our performance, and all the previous exams we have always gone through this nerve-wracking experience. So even the best of the students tend to lose that confidence or focus or the exact the skills that they need for the test. For the next whatever the past 3 years, not really now perform that one day's performance counts a lot. So that is why this whole program of I2I exams, you can get that confidence to look into the exam I2I, face it. That is the whole idea. So let's start from today. Dr. Deepti Joshi will take it from here. She is going to really give you some ideas about the tips and tricks that are necessary for the OSCE and Viva. Then I will continue with what are the basic principles of presenting a case. How to actually not to commit the most commonly done mistakes, which are so elementary, but still it is done in the exam. So let us try to next 1.5 hours, let us try to solve this mystery. Over to Dr. B.
Thank you, sir. Good evening, everyone. So I would like to share my PPT. So I would like to go ahead with few of the topics which would be kept in your Viva Voce table. And believe me, the platter on this photo looks very delicious, but then it's not so delicious or good looking when the platter is kept to you in front of your exam table. So first, there are three things which I would be touching for you. One set of instruments, one set of drugs, and one set of chart. So coming to because these are the three main things which would be kept on your table when you're facing any Viva Voce exam. So coming to the first set of instruments, I would be daily covering a part of instruments because covering up all the instrument fully wouldn't be logical for you people to remember also. The first set of instrument which I would be covering today is the pupil expanders. So remember, when any drug or any instrument anything which is kept in front of you, never take too much time to pick up anything. That itself proves that you are not prepared for your examination. And the moment you pick it up, the first thing you're supposed to say is what is the name of the instrument. So whether I don't mean like it is forceps or it's every forceps, every instrument has got a name. So naming them becomes the most important thing. So please remember the name of each and every instrument which would be most commonly kept for you. So coming to the pupil expanders, there are two type of pupil expanders. One is rings, other one is hook. So coming to the ring type of pupil expander, there is one hexagonal ring, there is a diamond shape ring. There are multiple rings, but these are the two most common rings which will be kept for you in the exam. So why did I mention the name? That's basically because the hexagonal ring is again named according to its own shape. So the name is B hex ring. So what is B? I told you, you need to remember the person or the whatever, whoever is the founder of it. So the B here stands for Bhattacharjee. So it has been designed by Dr. Suven Bhattacharjee, who is our own Indian ophthalmologist. And so B is Bhattacharjee, hex is the shape of the instruments, the B hex ring. And it is made up of polyamide. Similarly, if you see here, the diamond is Malujan ring. Why is it Malujan? Because it is being founded or designed by Dr. Boris Malujan. So this is Suven Bhattacharjee and this is Boris Malujan. So these are the people who have designed it, and they are the people on whom the ring or expander has been named. The rest of the thing remains the same no matter which ring is given to you. That is, it is made up of plastic. The type of plastic varies, whether it is polypropylene or polyamide. Both of these can be inserted through 1 to 2 millimeter corneal incision. Hence, they are most commonly used in phacoemulsification whenever there is a non-dilating pupil. And the pupil, which is about 2 to 3 millimeter non-dilating, when you insert these rings, becomes 5 to 6 millimeter. So, this is your ring which is kept for you. B hex ring, Malujan ring, found out by Bhattacharjee, found out by Malujan, and made up of plastic, inserted through 1 to 2 millimeter incision. So can be used in both SICS as well as phaco and makes the pupil about 6 millimeter large. The next is, I told you there are two types of rings. I mean the hooks. So what are the two types of hooks? If you can see the left side one, that is the iris hook. It has typically a hook-like thing. So you insert it through the side port. It's very thin, can be inserted through the side port, and the hook part goes and attaches itself to the pupillary margin, and you can pull open the pupil. So basically there are 5 hooks in each set. So you can insert the 5 hooks from different side ports as well as through the other ports which have been created, and you can make the pupil again into a pentagon shape or a 4 hook, making it into a square shape, and you can consider doing the phacoemulsification. Similarly, the other hook which is made up of steel or titanium, which you're noting over there, is basically the Kuglen hook. So it is clover leaf shaped. It doesn't have a hook similar to your iris hook, but it has got a clover leaf shape. So when you put the Kuglen's hook inside, this part of the Kuglen's hook, the clover leaf, the uppermost part, basically you go and push the iris. So you are mechanically stretching the iris, trying to dilate the pupil mechanically. The major disadvantage is it can cause atony. It can, in addition to the pupil dilatation, it can also be used to position the IOL. So this is the main types of pupil expanders which would be kept to you. So there were 2 rings, the hex ring, Malujan ring, and there are 2 hooks. They are iris hook, Kuglen's hook. Now this much you all know. But what will the discussion go on when this instrument is kept for you? So the first 3 most common questions which we have noticed our examiners asking when these instruments are kept is the first, what is IFIS? So IFIS is intraoperative floppy iris syndrome. That is one of the most common cause of non-dilating pupil. The iris becomes very floppy. It starts to prolapse through the main port, through the side port. When you're doing eye irrigation aspiration, the iris can just bulge up. Progressively, it becomes constricted. And so and it becomes tough for you to perform the cataract surgery. So that is an IFIS. The question which is most commonly asked are, what are the drugs which are responsible for the IFIS? So the drugs you have to name all the alpha adrenergic antagonists. So the drugs which are mainly taken by the elderly males for their prostate abnormalities or for the urinary retention, the alpha adrenergic antagonist drugs, these are the most common set of drugs which are responsible for IFIS in our Indian OT scenarios. So you need to name the tamsulosin, prazosin, finasteride. These becomes the most common drug in our Indian OT scenario where the IFIS can happen. So how do you tackle it? Obviously, you need to use intraoperatively. You have to meddle less with the iris. If the iris keeps prolapsing, please don't keep touching the iris and putting it in. Proceed with the surgery. You can use intraoperatively adrenaline to dilate the pupil. The next question which is asked, obviously you're talking about the pupil expanders. So what are the various strategies how you will dilate the pupil if you encounter with a small pupil in case of cataract surgery? You need to name all the drugs. The first is pharmacological dilatation, intraoperatively epinephrine, phenylephrine. Preoperatively, atropine can also be used in some children. When I am basically a pediatric ophthal, so when I do use for EUA or secondary IOL. Sometimes in non-dilating pupil, I do instill atropine ointment before using it, taking up the child for surgery. So these are pharmacologically dilatation. Viscodilatation, you can use viscoelastic agents and can dilate the pupil. Mechanically, I have already mentioned all the mechanical rings and the hooks. So these are the three ways in which you can tackle non-dilating pupil in case of small pupils. The last question which can be asked is, what are the other pupil expanders? These are not easily available in India, but then you need to know all the names, both for your theory and for your Viva VOC. They are Asias, Greether, Beeler pupil expander. So these are some names. Request all the postgraduates buy at them. They would become a part of your Viva VOC questions if these instruments are kept in your examination. So this was my first set of Viva VOC platter, and that is your instrument. So the next I come to drugs part. Now this is something which when a drug is given to you in your Viva VOC, the most common thing is the postgraduates pick it up. They don't say about the drug continuously. So you are supposed to say at least for the next 1 minute, pick up the drug and start speaking about it. There are some basic things which everybody knows. Like for example, look at the drug over there. The circle came, the name is there, the dosage is there. So pick up, say it is a timolol. So tell the dosage of the drug, which is already mentioned on it. So it is 0.5% timolol. The name is very clear. You need not think 100 times before you pick up and start rotating, seeing. Please don't do that. So the first thing you would be mentioning would be name and concentration of the drug. Then in which ophthalmic group, for example, anti-glaucoma medication, or you don't know you're supposed to even mention the pharmacologic group if you know it, but ophthalmic group, all of us know it. The pharmacologically, it is like beta blocker. What's the mechanism of the action? Then comes what would be the dosage we use, how many times we instill inside the eyes, indication, contraindication, side effect, and any special point if you know about the drug. For all the postgraduate, this was the mnemonic I used when I was presenting the drugs in my examination. So I remember it doesn't make any sense, drag disc, but then I think it helped me remember the name, how I would be proceeding with the drug explanation when I pick up a drug. So DR is drug name, A is mechanism of action, G which group. It would be best if you say both the group, ophthalmic as well as pharmacologic, but if any one group you can mention, that also would be very well. D again would be dosage. Concentration and dosage can be mentioned simultaneously. I is indication, S is side effect, C is contraindication. So now let's go back. This was our drug. Now let's go according to the drag disc protocol. So it comes as, the first one is drug name, 0.5%. So the name itself was mentioned, 0.5% timolol maleate. Mention the full name of the drug with the salt which has been used in it. That would be really best way in which you can explain the drug. Second one is A. So mechanism of the action, reduces aqueous production, beta antagonist, beta blocker drug it is. So it actually reduces the aqueous production. G, that is group. So you can mention both the groups. Ophthalmically, anti-glaucoma medication. Pharmacologically, it's a non-selective beta blocker. So fourth is D, that is the dosage. So depending on what is the concentration, 0.5% or 0.25%, it can be BD dosage, OD dosage, long acting. So all those you can mention. Most commonly timolol is BD dosage. You wouldn't be wrong if you mention overall a BD dose for it. I is indication, ocular hypertension, open angle, angle closure, and secondary glaucomas, all type of glaucomas in fact. So S is side effects. So you can mention both ocular side effects and systemic side effects. The systemically, you know that both respiratory and the cardiac side effects has to be mentioned. Ocular, for any drug you can mention the way we used to mention in pharmacology, nausea, vomiting becomes a overall side effect. Similarly, here the ocular allergy, burning, stinging sensation, all these comes under your ocular side effect. C is contraindication. Obviously, the side effect is respiratory and cardiac. So it cannot be used in respiratory, bronchial asthma, COPD. Cardiac, because it causes heart block, it cannot be used in bradycardias, heart blocks, or cardiac failure. So this is easily, you have mentioned all the 7 points according to the drag disc part. Now I told you there are some special point. If you mention about the drug, given one special point about each drug, I think that your examiner will really be happy. In case of timolol, even for your theory purpose, I think all of you have already done with your theory, but then short-term escape, long-term drift becomes one of the point which you will mention. That is the tolerance of the drug, and over a period of time, the drug stops working. That is your long-term drift. I'm not explaining too much about this. This you will go back and read. You can message me personally what is short-term escape and long-term drift. I would be really happy to get. You all have my number now. So you can just message and let me know what is short-term escape, long-term drift. So any drug comes to you, you will be explaining it on the basis of drag disc. Now let's go ahead with one more drug just for a short wrap up. So before we go ahead with second drug, remember the other questions which can be asked is, if a timolol comes, what are the other beta blockers? There is betoxolone. This is the only one, B for B. Okay, only one selective beta 1 blocker. So the rest all are non-selective beta blocker. Betoxolol is the only one selective beta 1 blocker. B for B. Another B is less bronchopulmonary side effect as compared to timolol because it is selective beta 1 blocker. Okay. The C for C. The next one is cartiolol. So these drugs are not available, but then your theory, Viva VOC, this can be asked. C for C, cartiolol. It is lipid friendly, cardiac friendly drug because it has got intrinsic sympathomimetic activity. L for L, levobunolol, longest acting beta blocker, which is available in the as an anti-glaucoma thing. Metipronolol, this can occasionally when used can cause granulomatous anterior uveitis. I couldn't make any mnemonic for the last part for you, so by at the metipronolol part. But otherwise, B for B, C for C, L for L, timolol, I have already told you as a whole. So coming to the drug, that is your drag disc. Now we go ahead with next drug. We will just wrap it up very fast. DR. So what is the type of the drug now? It is prednisolone acetate. I already told you, open the drug, see the name of the drug, it's already there. So DR is prednisolone acetate, 1%. A, what is the mechanism of action? It inhibits your, obviously it's a steroid, so it inhibits the inflammatory response. That is, it acts on phospholipase pathway, and because of which it reduces the leukotriene release and it inhibits the inflammatory pathway. G is, what is the group? It is a steroid, adrenocortical steroid, and the dosage 1%, depending, it can be used from 2 times a day to 3 times, 4 times, tapering dosage. I is indication. Steroids have a wide range of indication: allergic conjunctivitis, flictenular conjunctivitis, rosacea, uveitis, chemical burns, graft rejection. Mention anything in ophthalmology, steroid has a use in it. But what are the side effects? The most important is glaucoma, cataract. So these two things has to be mentioned. Most importantly, the PSCC and the raised intraocular pressure. So contraindications will be fungal corneal ulcers and steroid responders. So with this, we have mentioned using drag disc. We have mentioned the second drug now. So you didn't think twice before explaining the whole 2 minutes part of the drug. So this was about the drug. I think next time when I open up the drug part, I would expect one of the PG who would be there volunteering for the case presentation to come up and explain as much as possible about the drug using the drag disc. Okay. So the last part which I would be touching today is charts. So I told you the charts part which would be kept, perimetry and all would be covered by sir. Some parts of the chart I will be covering up daily. So today I have used up the color vision chart. This is available in all medical colleges, all institutions, irrespective of where you are studying. A color vision chart is mandatory. Unfortunately, not many people know that the Ishihara chart itself can be explained for a period of 1 to 2 minutes if you just hold it. Because whenever I have noticed in our I2I Viva VOC, people pick up Ishihara chart and they say, this is used to check color vision. That's it. Beyond that, you don't know what happens inside the Ishihara chart. So this Ishihara tests basically is available in two. The photo what I have put is 38 plate edition. Many colleges do have 24 plate editions also available. So when a Ishihara's chart is kept in front of you, see whether it is 24 plate one or the 38 plate one, and it has to be kept nearly 75 centimeter away. Each plate has to be identified within 3 seconds. That is the norm for a Ishihara's test for color blindness. So the first, there are out of those 24 plates, each plate is actually has got its own work and its own activity. For example, the first plate, you have actually, I have put up the number and I have put up the type of the plate. So the first plate is a demonstration plate. The first plate will actually be seen by both normal and a color deficient person. So if a color deficient person is not able to see first plate, he is malingering. So that is one of the first use of another, the part of the first plate also. So that is the first plate, which is your demonstration plate. Second to ninth is actually known as transformation plate design. So normal and color deficient people see different numbers in it. But the color blind person can't see it at all. 10 to 17, only normal people can see them. 18 to 21, so both only colorblind and color deficient people can see. And the last one is used to differentiate between protons and the deuterons. So the type of color blinds, what are the types? So both will see different numbers. Then only normal people will see, only colorblind people will see, and types of color blindness. This is how the each plate of the Ishihara goes. So that book is 24 plate. Remember, each of them have got its own use. So if you cannot remember the number of the plates, at least tell them that these are the plates: demonstration, transformation, vanishing, hidden digit, and classification. So at least it will fetch you some marks when you lift it up. Now, what are the questions which can be asked if a Ishihara chart is kept to you? What are the other type of color vision tests? There is Fansel-Munsworth 100 hue test as well as D15 hue test. Then there is, what is this hue test? I'll let you know. So this is basically Farnsworth-Munsell 100 hue test, where the colors are basically arranged in the form of hues. So like orange, yellow, green, blue, blue, purple, and finally pink shade. So the first and the last one would be given to you. You have to arrange the rest of them based on the hues. So depending on how they arrange, you can actually find out what is the type of color blindness. In Farnsworth-Munsell 100 hue test, you are checking up all the shades of color blindness in the patient. So, but the only problem is that it takes a lot of time and lot of patience of the patient. The smaller version of it, which is available with most of the colleges and the institution, would be the 15 hue test, where we only check the red, green or blue, yellow part. So these only 15 hues are present, easy to keep, but only those selected hues are being tested. So these, in addition to Ishihara, you need to know Farnsworth-Munsell 100 as well as D15 hue test, because most of the institution have them also. What are the other ones? There is anemonoscope. So where basically one part has red and green color, other one has yellow color. You have to mix and bring it nearly to yellow. Lantern yarn test. You have to remember all of them. Physiology of color vision. I think no book other than Khurana mentions it in a real nice way. A note to Dr. Khurana, we just lost him recently, but it's the best explained in your physiology book. any color vision chart which is given to you, physiology of color vision will be asked. So you need to know it completely. And the next question which can be asked is types of color blindness. So this has to be biated. What is monochromatism? Patient will see only one color, that is gray. Dichromatism, patient sees only two color. So it is basically he will be seeing blue green, or he will be seeing red blue green, depending on which type of the rods or cone is missing. And trichromatism, where that all of them are not aligned. So protanopia, deuteranopia, tritanopia, or protanomalus, deuteranomalus, or tritanomalus. So these are the types of color blindness which you need to buy at, can be asked for you. So this part I have finished. So with this, I wrap up today's instruments, which were the pupil expanders, the drug part, which I've told you, the drag disc. Tomorrow, I think I would be asking you to present the drugs to me, and the instrument part will be oral, open on YouTube for you to answer. And the chart, I would touch another new chart tomorrow. So with this, I hand over to KP sir for the rest of the part of the session today. Thank you.
Thank you, Dr. Deepti. I think has started the eye-to-eye discussion. Now over to, can stop sharing. So now, as always say in eye-to-eye programs, see, when you go to a practical exam, they're going to keep cases. Actually see patients, or rarely for funders, you can actually see chart. Okay? On a laptop, they will show you a photograph. Make your case discussion on the basis. But most times you may be able to actually ask to see the patient also. But the other cases, definitely non-funders cases, you have to see the patient and examine and write it up and then present in front of the examiner. A typical exam situation is the examiners have been examining a lot of people, sometimes anywhere between 7 to 10 in one day. So obviously, they are impatient. They don't have all the time in the world to listen to all of your. So if you can, in a short time, convince or convey the information that you want to tell in a very crisp manner, they will be actually very happy. That can result in better marks. At the same time, you also have a situation. See, it's all about guessing, rehearsing, and trying to go through a simulation process to the exam. I told you why exams are difficult, because you have not really gone through the simulation. So you should be ready for all possible situations. For example, you may be given too short a time. For example, when you finish something, they say they've given you the cases. The examiners can't sit for, let us say, 1 hour waiting for you to take both the cases. They will say in half an hour, get the first candidate. You may be the first candidate where you are hardly given 15 minutes for each case. Or you are seeing one case fully and the other case you are just beginning to see. They say, it's okay, you come. So if you are going in very short time, then it works to your advantage. You don't have to write anything. Just go there and you start telling. Just because they have given you less time, they will be definitely aligned to, some kind of a sympathetic approach, because you've not been enough time. And whatever findings that you have not seen or you don't know, you can always say, sir, I want to see for this, I want to look for this, but I need time. I was not given time. Or there is a shortage of. I want to do gonioscopy because I'm expecting this. I'm not done it. This is very important. See, whatever you have not done, you have to say that you want to do. Doesn't mean that you have to do everything on the patient, but you should know what you're expecting. In a particular case, you want to do a gonioscopy, the examiner will ask you, what do you expect in the gonioscopy? Then you should tell something what you are expecting to see. At the same time, if you are not seeing, if you have not done an investigation or a clinical test, like you have not done a Schirmer's test, say, sir, I was not enough time for me to do Schirmer, but I would like to do a Schirmer's. This is exactly what you're going to tell, right? At the same time, you may be the last candidate where you've been waiting from morning till all the candidates finish. You are the 10th candidate and trying to go there. The examiners are extremely exhausted. They are ready to get up and go. We have their travel plans. And now you start your history. So that may also work to your advantage. Then try to bore them. It is very important. Is try to think what all cases can be kept. If your institution is hosting a practical examination and the kind of cases that you get in your OPD, so obviously you're going to shortlist them and bring it to the exam. So obviously you don't get something which is an acute case. You don't bring an orbital cellulitis and keep it, or you don't give a very painful situation, or you don't keep some kind of a malignancy with a lot of pain. So you normally tend to keep cold cases, like a healing corneal ulcer or a post-keratoplasty situation, case of glaucoma, which normally come to that examination. There are some institutions where there's a lot of workload, then you may get some exotic cases, but most likely, like for example, proptosis. Earlier, proptosis used to be a case because a lot of orbital tumors would be moving around for years together without getting operated. Now you have a lot of orbital surgeons available, so you don't really find any cavernous tumors moving around available for the examination. If it happens to come within few days before the exam, it may be kept in there. Even ptosis also. There's some ptosis, since ptosis is so common that it can come in the examination. So you should understand what are the most likely cases that you are going to see. See, what are the most likely cases? Let us say in cornea, it is keratoconus. Because keratoconus won't go away, even with C3R treatment also. Keratoconus signs will be there. So keratoconus is one case that you should be always ready, and you should know how to read a topography. Same time, you should know what are the basic signs. And examiners are all usually are not cornea specialists. This is another important thing. Most of the examiners are college professors who will be usually comprehensive ophthalmologists. Rarely you may find a specialist. Somebody may be a somebody may be a cornea, retina specialist. But having said that, most of them are likely to know something about everything, not in great depth. Okay. So it probably serves you well if you know the specialty of the examiner, but be ready because obviously they're not going to ask in depth about the keratoconus or the latest things that you see only in the cornea conferences, but you should know something about everything, but they also know. Okay, so you cannot miss out the elementary. Then what is the other cornea case? It can be, let's say, keratoplasty. So once you have done a keratoplasty, either an optical or a therapeutic, whether the graft is clear or not, this patient will be an example. Because there can be a discussions on all about keratoplasty. Be penetrating keratoplasty, maybe lamellar keratoplasty, indications, problems, contraindication, different types of suturing. There are all about eye banking, corneal preservation. There can be host of topics that can be covered with one case. That patient may also have a post-PK glaucoma, so that the discussion can be on glaucoma. Or there can be on the indications for keratoplasty and discuss about the ulcer, adherent lipomas, pseudokeratoplasty keratoplasty. So you should always think this case could be a case. So whenever in the next whatever few weeks that you have for your or months you have for the practice, imagine a keratoplasty case and try to go through this. And about corneal ulcer, this is very common. Bacterial ulcers usually heal up quickly. It is the fungal ulcer which drag on for weeks. So usually fungal ulcers are more common. And the most common question is to make they will have you have to write a cornea diagram with all its details and make a diagnosis whether it is bacterial or fungal. Okay, usually it is fungal, but you should know the signs. It may be a healing ulcer for all that. It may not be all that finding that you see in a program. It may be a healing ulcer also, only minimal findings. So you should also know how to differentiate a bacterial plus fungal. They may ask you about the acanthamoeba, the other types or viral ulcers. So the other microbial ulcers, you should also be having some idea. So these are the usual common. And the next is glaucoma. See, glaucoma cases are the most likely for your exam. Glaucoma cases because POAGs, ACGs at different stages. You will always have a disc finding. You cannot have perimetry printouts of the same patient. You will definitely have some anterior segment findings. There will be even pseudophakics, or there may be even there is a possibility of doing a gonioscopy. There may be a PI. There may be a previous trabeculectomy. There may be a glaucoma shunt there. So all these are very common likely findings in a glaucoma patient. So your discussions can go on anything, starting from classical different IOP measurement, just risk awareness, and also of the target IOP, for perimetry, for the new disc imaging or OCT or XRP, and about the different glaucoma surgical laser procedure. So you should be ready about these things, and glaucoma cases. You may also have rarely neovascular. See, most of neovascular glaucomas are symptomatic glaucomas. Most instances they are given either an anti-VEGF and the rubeosis disappears. So it is very unlikely that you have an active rubeosis and you have a neovascular normally. But you cannot say if the patient they find a neovascular glaucoma case, exam, case, you should know what are the most common. For example, order is very important. So whenever you think of answering such a question, why I'm telling you this is it's about all about it. When the best student answer and the confidence and the speed with which you answer in the order or the sequence can impress the examiner, obviating the need for further questions. For example, if you say what are the most common causes of neovascular, the sequence is very important. First, you say vascular that include venous as well as artery. That includes branch as well as CRVO, BRVO, CRAO. Those four become the most common. Immediately followed by proliferative diabetic retinopathy, most common. Third one is you should know the ischemics. Then you may not have any funding in the fundus may be featureless, patient may not be diabetic, still you may have uveosis. So this is very important thing that you should know the third most common. Later it can be uveitis, it can be tumors, it can be colds, it can be end-stage. Most of causes they are not very toxic and the management. So we basically take the posterior segment because most of this is basically back and just forward. So we take the posterior segment. Till then you manage medically, then you always do the public health procedure. So this is how you probably plan for it. See, for anything, always think of some acronym, some kind of a short. For example, the next most common cause is neuroophthalmia, third nerve palsy, and usually both can be diabetes. It can. These two will linger on for a few months, and third nerve palsy can recover completely in a diabetes, can recover in a coma. They continue to be exam cases. A lot of discussions can happen. So normally examiners do prefer to third nerve and sixth. So you should be ready with such. So normally, if the patient is diabetic, then it is very clear that you are talking about it. At the same time, don't just jump that it could be done. Patient has an RTE or a closed head injury, showing which there was a third nerve or a sixth nerve. The post-traumatic sixth nerve. Again, what I'm trying to say is you should always format the answer. So normally some of the students in some of the medical colleges are into too much of formality. Undergraduate case, they take in such detailed exam. They talk so much about the personal history, bowel, bladder, this, that. See, case presentation is right. You have seen the patient, you want to come professionally both of it. You should actually try to save time. So don't try to, give negative unnecessary. People say that negative histories are important, no history of redness, watering, discharge, which is irrelevant to the case. Don't talk. If you're talking about a traumatic six-nerve palsy, okay, you should not be giving a negative history without any explanation. Whatever negative histories you should have a negative. So let me kind of exemplify. For example, if you're seeing a case of ptosis, say ptosis is another very important case because you do find a lot of kids, even adults and adolescents, for not getting operated. So they continue to come to care that can be kept the case. So you have a congenital variety and you have even acquired variety. So you can always have old people coming with ptosis. So you can have both the varieties. So if you see a child and the ptosis history is even since their birth or early childhood, most likely you're talking about it. So let us try to start thinking about what can be the history in a congenital. Don't try to give a two-page history. Not really necessary. Okay, the history itself says that it is since birth. So it is congenital. Obviously, it is not an acquired. So don't try to talk about acquired causes. So don't try to say there's no history of trauma. What are the acquired ptosis causes? Most common one is senile. Obviously, the child you're not going to. The next is aponeurotic. Aponeurotic can be a part of the senile. It can also be following a blepharochalasis in adolescence. Okay, that is aponeurotic. Where there's an aponeurotic. And the most important differentiating factor is ptosis. Normally, in a congenital ptosis, amount of LPS action matches it. You have a very poor LPS action, have a severe dose. You have a fair amount of LPS action, you have a mild. It is amount of contractility of LPS. Whereas in an aponeurotic process, there's a disinsertion of any sense of opening. LPS muscle is, you have a good LPS action, it cannot stay there, it usually comes down. So you have a severe ptosis with good or fair LPS. They don't match. The LPS action is pretty good. By Merca's method, the excursion of the lid is pretty good, but the lid is severely poor. So that suggests diagnosis in Apollo. So the next variety is urogenic. In Horner's, third nerve. In Horner's, you have a small pupil. In third nerve palsy, normally in a traumatic case, you have a large pupil. Next is myogenic, is usually masking. Masking is very, very unlikely. So don't talk about mass. Right? Asthenia has typical variability. So after the person. And normally they also have the and the amount of doses can vary. So this variability is very. And after a period of rest can get better. Have Fobon's lead sign pattern. Please understand myasthenia can also be if you no examiner will miss it, because it's a very rare case, very commonly found examination. Okay? So how to different tests for mass? What are the investigations that killer as well as the system? And myasthenia can be a part of the systemic myasthenia. Treatment protocol that can be a myogenic and mechanical and traumatic are obvious. Mechanical inhibition. And a trauma obviously is following it from. So congenital ptosis is obvious by history. Then what all history you can take in a congenital? I am interested to know whether this ptosis is variable, not because of myasthenia. So the child can actually use frontalis and lift the lid up. Child does not want to use frontalis because of the fatigue of the frontalis. It can actually release the frontalis later part of it. can be a small diagonal variation even in the tendinitis. The next is the ptosis severe enough? Is it covering the axis? The child has an anomalous head posture. The child has chin elevation unilateral or even the back. What does the say in a unilateral? The child wants to see binocularly, then only it will lift the chin and try to see binocularly. So an anomalous head posture of a chin elevation is a good for the child is accurately. Chances of amblyopia are one. There is a severe unilateral ptosis. Child is not doing chin elevation to expect vision to be less. That is the history. You ask the mother, the child lifting the chin always and trying to see. So that says that binocular vision present itself. At the same time, is the vision normal? For example, by history also, you can know the child can be big enough to say that I'm seeing less in the right. Right? Means the child is accessing less because of and the history. It can be by history. You don't have to even examine the child. So that you can come. So what is the effect of observation? So all these can be in the history. And we'll come to examination. See, there are a lot of things that are told, but importantly, this is all about symmetry. About light and so what are the things that you see? Most important to write is amount of ptosis. Amount of ptosis is extremely. So this is actually a millimeter. For example, if the cornea is, let us say, 7 millimeters long, top 2 millimeters is covered by the lid. You have only 9 millimeters. The center of the cornea, where the Hirschberg is around 5 point. So if the lid comes down by, let us say, 2 millimeters, it comes closer to the. So then the distance between the Hirschberg reflex policy. So there has been a practice of late to RD1 and 2 rather than the amount of 2. It is better to actually put it in the beginning as the amount, how much of lid has come. So if you want to really convert the two, 3.5 minus your MRD1. Let us say if your MRD is 2 millimeters, MRD1, 3.5 minus 2, 1.5 millimeters. So please write the amount of processing. Then you write the amount. MRD1, how you do next, the lower lid. That is usually around 5. But if there is an associated interaction, then it can actually kill. The next most important measurement is you are doing it on both the eyes. Palpable aperture. Primary gaze, up gaze how much? This has to match. You have to compare with each other. And one important catch here is word and congenital. Because the LPS muscle is dystrophic, when the lid goes down and stretch because of the dystrophy. So there is some amount of lid lag. So the palpable aperture in the down view wider compared to the normal. Okay. So how do you, if you do not know the history, by examination finding, how can you detect a congenital process? If you see the down gaze, there is a lid lag compared to the whereas in an acquired process, it is reverse. Palpable aperture will be narrower. Okay. This is another comparison only by examination, not by. Okay. So the next is LPS action. LPS action is the most important thing. It actually should match with the ptosis. LPS action by Burke's method is to neutralize the flow. Thus, less expensive that we need. So you have to do something really also both qualitatively and quantitatively. Where fair or excellent the qualification qualified. Next, there are two phenomena that we need to talk about. One is Bell's phenomenon, extremely important. In fact, it will decide whether there is surgery. Bell's phenomena should again be quantified. Not in, so basically, you have to say it is absent or fair or good. Normally, you will never operate in ptosis case if Bell's is because if you do a surgery, generally, this is something very important. So, you will normally ask you, patient has severe ptosis, very poor LPS action, and the Bell's is poor. What is the solution? Or to the class, you say no surgery, touch class. That is the answer. Next is Marcus Gunn. So when the patient moves the jaw or opens the cavity or opening the mouth, here we deliver. This is Marcus Gunn because of aberrant. This is always condemned. Never have this. Usually Marcus Gunn and manage a Marcus. Now, if you get a Marcus Gunn ptosis, you think that you are past. First pick up the Marcus. Same time, you have to discuss how you manage. Please understand, not all Marcus Gunn ptosis are treated differently. The congenital ptosis, we call it as a complex. Simple ptosis is one, is just a ptosis. Which are the complicated ptosis? Complicated ptosis, what is associated with what? Is associated with hypertrophy of the element. So this is another case. And the ptosis associated with these are the complicated. So if you say it is, how do you tell the diagnosis? It is a congenital ptosis, simple or complicated. Simple is just a ptosis, but it's a complicated. Again, it can be a mild or moderate. It can be associated with Marcus Gunn, associated with mononuclear elevation. Patient may also have even strabismic cavity, so that you need to know. So these are complicated ptosis cases where there's a lot of discussion, and normally, even if you answer little, the will be. So how do you manage a Marcus Gunn? A typical severe Marcus Gunn, and the patient is interested to get rid of the Marcus Gunn. Normally, you need to sever the apology and create a total ptosis. Go to LPS at the Wittnall's ligament, cut the Wittnall's completely, and disinsert the LPS completely. So that any aberrant innervation will not. Then, and lift the lid here. There's a complete ptosis because of disinsert. Is the ideal management of a severe Marcus Gunn is LPS aponeurosis followed by frontalis lesions. Having said that, if the Marcus Gunn is very small, very mild, patient is not keen on it, you can treat it like a. What is the problem if you do a simple LPS resection in case of your severe Marcus Gunn? You will be strengthening the elevation action of the knee. Marcus Gunn will improve. Patient is keen on Marcus Gunn correction. If you do a simple LPS resection, Marcus Gunn phenomenon will get exaggerated. At the same time, you have all the problems of a frontalis. So what are the two problems of a frontalis ring suspension? For one, patient leg will not come down or it is held by a lid lag in down gaze, a lag of time. It cannot completely, okay, there is no stretchability. So lag of thalmus and lid lag. So are the two common components. It will be done unilateral. There will be an asymmetry. Patient looks down and both eyes will go down, but only one lid will go down. So when these are the things that are commonly asked, the problems of frontalis linsel. And what are the materials used? Nowadays we use a silicon rod, silicon whereas you can also use a 40 ethylene unabsorbable. The biological substances, autologous facialate, the common thing that we use. But you should know what is the patient's own face. But presently we are using, that is the whole idea. Then after Marcus Gunn, there are two lead things that is okay. One is lid crease and the other is okay, lag of thalmus and lid lag. So if the patient preoperatively has lag of thalmus and lid lag, your ptosis surgery is going to worsen. The exposure keratopathy chances are so always document lag and lag of thalmus in each case of there is a very severe lag of thalmus and lid lag, and you have to suspect that there will be a corneal exposure. Then the lid crease is important. See, it is so the lid crease is of lot of cosmetic importance. You need to create the lid crease. Slightly like the other eye. So the normal eye, you need to measure the lid crease and create a lid. So your incision on the lid will be at the proposed site of where you want to create it. You are taking it. This is something new. At the same time, if there is an aponeurotic process, because the aponeurosis has given away, there is a gap. Normally, it is attached to the tarsus, front of the aponeurosis gives way. Above the tarsus, there will be a gap, a sulcus. Supratarsal sulcus or upshifted lid crease, the sign of aponeurosis is something. And the most important part of ptosis correction, this one, motility. Apart from bells, also try to find out the change in the ptosis with the eye movement. And most important, okay, in this you can also add what is full cover test. Why cover test? Because if you just cover the normal eye, happens to the tooth. All that you may be dealing with, yes, pseudo. Patient has hypertropia, then the use without any problem in LP can have a ptosis-like picture when the eye is hypertrophic. So there are situations where both LPS muscle and superior rectus muscle both are dystrophic because they share a common element. So you may have a combination of pseudotosis and ptosis. So you may have a congenital ptosis, a complicated congenital ptosis, where patient has ptosis, patient also has hypertropia, so he has an additional element of pseudotosis. So then how do you examine, how do you do ptosis work? You have to patch the other eye and do the entire process. So that the actual true ptosis can be evaluated and you should do surgery first for the eye alignment. Want to do a squint surgery, you are going to right and inflammation. Very rarely you may even do a horizontal rectangle. Lift the eyeball up, align it horizontally, then the pseudotosis will disappear. And whatever remains in the true that will be okay. And on the last, we should always talk about corneal tear film corneas. Because if the patient has hypostasia of the cornea, I mean the corneal tear film is good, so very high chances of corneal. Yeah, most the most important complication of corneal damage. All these processes work up. Is one is to amount of LPS resection in the segment. Second is to expect and to circumvent the ill. So this is something that. So how do you actually give the diagnosis of a ptosis? Basically, you say congenital, partial, can be congenital, complicated, partial with Marcus or with monocular elevation, hypertrophy. Or it can be an associate. Normally, if you have a blepharophimosis, epicanthus inversus, 100%. Bilateral condition by the maldevelopment of the this. The components are four components are there. One is bilateral severe ptosis. So for LPS, we have bilateral severe ptosis. We have blepharophimosis. Palpebral aperture much shorter. Frontal aperture. Third will be the telecanthus. Space or the gap between the period. Sometimes canthus inverse. So this is a surgery. We need to do a surgery to correct each one. So how do you increase? How do you increase the basically the lateral canthotomy, lateral canthus in palpebral aperture? You take out the telecanthus. Do what is called a ceuplasty with or without a transnasal wiring, so that you can increase the skin, extra skin in the middle palpebral ligament or medial canthal tendons more to the side, so that the full tarsal uh, is pulled. And the ptosis you do a frontalis linctus. You can't do an LPSS. So these are the combinations of surgeries that we do for the blepharophimosis, epicanthus. And coming to the third nerve and sixth nerve palsy. See, whenever this case is asked, go with the because this is a one test, which is one case which is usually expected. There we keep it because these cases don't recover very quickly. Common to have diabetic third nerve and sixth nerve, and trauma invariably they will have sixth and third nerve palsy. So now let us see the more common one, that is the diabetic one. So if there's a third nerve palsy, third nerve diabetic palsy, let us try to conjure up what will be the finding and what you are going to do. What will be the presenting findings? Let us say the presenting findings will be patient will have complete diplopia. So the patient will just have diplopia. So the diplopia in a third nerve palsy will not be immediate, because once you have a ptosis, if I'm talking about diabetic third nerve palsy, once you have a ptosis, there will be no binary. So patient complains of only drooping of the lid. Patient comes with drooping of the lid. What it is? To lift the lid and see is down and out, because only lateral rectus and superior oblique are active. Things rise down and then once in a diabetic palsy, normally by 4 to 6 ptosis start, then the lid lifts up, the patient starts. If you see very early, only with the drooping, then patient may not. So you need to say the patient from last 3 months is last 1 month is complaining double vision. Use the word diplopia. Some examiners don't like technical. So say double vision. So if this is the case, you need to expand both of these ones. Like grouping was total, gradually it started improving after 4 weeks. Then the patient is double vision. Whenever there's a double vision, we find that further points. Ask the patient the history. Does it disappear after closing? Does it continue? The history. Patient says even the turn. Then we see, ask the patient, are they horizontally separated or vertically? Sometimes they can be a combination of actually. In the fourth lobe palsy, patients say even torsionally, hearing is not. Next, you say, what is the change in the double vision with reference to the head post? In the sixth lobe palsy, patients are looking to right, not looking to left palsy. So change of double vision. Same time, does it increase in one particular case? So change double vision with reference to the case. Then change of double vision reference to a particular head post. He says, I am turning my face to the right and fine. Palsy. Six palsy, they feel this practice. Okay. So this head posture and position change of the can also be a history. So we can really come to know many things. Then what is very important is this is about double vision. Now what has caused the double vision? Okay, obviously it can be an intracranial event, it can be a has variability, fatigability. So these are basically asthenia. And then but usually if you, in the absence of all these pillar or orbitals, obviously we have, this is one area where order of trying to tell you what can go wrong. Anything intracranial problem, only very few, and you can use some acronym. Most common intracranial problems are that it is talking about palsy or supranuclear palsies, gaze palsies, all these intracranial problems sequence. Number one is vascular. V for vascular. Vascular can be infarction, hemorrhages, can be AV malformation, can be VNS. All these things, the, all these come vascular. The next is infections and inflammation. Third one is neoplastic. Plastic health the most important ones to be done. You have no clue unless you are doing it. Not really. Next is demyelination. So, that a problem, demyelination and including that. Demyelination is always on lastly metabolic like that. NDT, vascular infection, plastic, demyelination, hepatic, and you can add to that metabolic. These are the most common intracranial problem. One of them. All your investigations. So let us take a typical case. How will you discuss diabetic third organs? Let's say patient is already 3 months old. His process is partially recovered. What will you do? How will you most of the diabetic has recovered because it's a neurotransmitter. Problem is microangiopathy of the nervosum. That supply to the trunks of the. That's why the pupil has trauma. The pupil trauma. How do you know? There's a history of trauma. Number one. Number two. You said you can take total third now. That is even. Number three. There will be an aberrant regeneration happen. Mismatch fibers from MR will go to nucleus and vice versa. Have lead interaction. Have pseudo all these apparent regenerations have a dramatic turnover. So, how do you basically manage diabetic turnover? Spontaneous recovery is usually or till the time no further recovery happens, recovery is late. Okay? It can happen. And during this time, during the time of recovery, the subjective can you do that? Actually, okay, certainly. That's the paratici, that's the Indian. Creating the pineapple. And number two, this patching the normal eye and making the eye to move prevent the contracture of at the middle at the same time, the lateral rectus. The second thing that you can do is check botulinum toxin. MR in 5 minutes. Check into the vessel. Transient innervation is the speed of recovery and it will and also prevent the contraction. That time. So you wait for 6 months or the 7 months or 8 months. Then you assess the final popular mode. Not that everything will recover all the time. It's not necessary. At least everything will recover completely. There can be some trauma will be always some visibility. So then to correct. For example, if the ptosis has completely recovered, I used to take it down. Or there can be different upon the SR and IU, or it can be up. You basically correct the horizontal muscle. India is to only create free. Not in all cases. Third now it is not possible. Aim is to create a diplopia free case direct so that you can do lateral rectus. You can also probably do transfer whatever you present. These are for third now. Six now is pretty easy. Six now is only one muscle. So patient will have double, patient will have a head posture. And at the same time, if the patient is complete in a diabetes, you don't have to do anything. And inject botulinum toxin to MR, which is clear. In case of a residual isotropia, after the complete time that you is isotropia, then MR recession. For that, with FD, our decision and with continue. If the still there's a residual isotropia, then you do an FGT. If the lateral vector still has some contractility, you can resect the lateral. Lateral vector is completely in any contractility. That's just what I okay. So trauma, normally third node you will have apparently be a recovery of the process, increase in the apparently fibers from the third node. So these are some of the situations that you should be actually trained. And as Dr. Deepthi also about the especially DNB students, the cases 100 marks out of 3. But you have another 100 marks for table 1. So that is where you have almost 1/3 of the marks discussing drugs, devices, and lot of discussion can happen on the, like for example, let me keep an IOL. It is any hospital have an IOL box, they can start discussing it. Examiners are not very not know only about some Okta investigation in Okta, not able to read some very there in this fine. But if you are not able to tell something about intraocular lens, then you are able. First, they are going to expect you to know. For example, they keep an IOL box. They will ask you what are the new things that in IOL technology, what are the IOL. It can be a simple question and boil you out, not really formatted the answer. At the same time, there are still certain tips I always want to give. Always start the answer very quickly. Read for tool. In 3 seconds. For one, always tell the most common thing. Most common. That is why I say you have to that's formatted. For example, if I say, what are the two technology of IOL or what IOL technology? Hey, you have to know which one to say. Even let's say you have started wrongly, you immediately follow it up with the other answers, then it gets submitted. If you tell the least important thing first and give a gap of 15 seconds, examiners will do. For example, what is the most latest thing? It is the polymer. All second. Same polymers are very capsules. Also, for example, actors of materials from. We can give some examples, no problem. The second most important thing is now we have aspheric lenses. We can create an aspheric surface on the back surface, but we can take care of the corneal spherical element. Better visual. So to take care of corneal spherical element, these lenses have negative spherical element. They're new development. Okay. The third thing is storicity. So the corneal astigmatism, pre-existing corneal astigmatism, counteracted by creating toric surface, lens can take care of it so that we correct the corneal astigmatism IOE. The next development. The fourth one is multifocality or trifocality. Can create multiple focal points by various mechanisms of apodization, creating ridges. Okay, so that we can create a multiple areas where the patient can actually focus on near intermediate and we may ask you what is the difference between multifocal, even though it is the thing. Multifocal lenses have poor intermediate vision. That 80 centimeters is normal. That's so multifocal lenses have good near vision and good distant vision, but poor vision. In order to take care of that, some optical change has been done so that the intermediate is more physiological. To differentiate these lenses, bifocal have good near intermediate. Okay. We will ask you some examples. Some of them examiners are actually cataracts. We should say one example of a trifocal. Can't even say one example, then you're not ready for life. Okay, so at least for one. For example, trifocal. So at least panoptics. Name. I mean, whatever is your choice. So name of one most commonly used names you should call in your institution. If you go further on, you can add chromophore, the colored lenses, yellow tint, the blue light as well as the create a better 3D macular problem. You can add colored lenses, or add chromophore to mimic a natural lens. So these are could be some of the things. And latest ones, you have what's called light adjustable lenses. Future. I have aberration free lenses. Have customized lenses to take the aberration, not the spherical, but the other aberrations. That is the future. So one just by looking by one simple can create a meaning. And as Dr. Deepthi already alluded, instruments are very important. Have a spread on your table. The last 5 minutes I'm going to spread, cover this and then get this talk. You have a spread of instrument. When you come to the Viva table, just take a look at what is there, like a memory test in childhood. So just look at it and try to find out what you're familiar with. Sometimes the examiner will hand over the first, but sometimes the examiner is in a put to there, of some fun. He say pick up an instrument. It's a trap. Okay. So you start looking for, start searching the table, goes against everything on it. Looking for it, but for no other things. So that's why you see before and try to locate a ready and casually, as if you are picking it up by chance, is number one. Okay. And don't pick up an artery force. Meeting instrument that is a scope for this. Take it up and don't look at it for too long. Okay. So you're not seeing it for the first time. And hold it in the anatomical way. For example, if it's a syphilis PCR punch, you're supposed to hold how it is being used. Okay, don't it ulta or something. And try to look at certain things. Some of them have certain engraving on that. For example, a punch has some numbers on it. Has a 2 or 3 or 4 limit written. You should know what it and at least start answering those. Example, if you take a syphilis, okay? So this is stainless steel, this is a titanium. You can even call the metal titanium punch, PCR. Is make diagnosis surgery. Preferably avoid using some acronyms are very common, some are more. Don't say CNV here. Always use full function. Diagnosis. Okay, then have you finished? No. Examiner still keeping. You continue. Never stop answering, don't give too long pauses, examiner to interview. So this is has got, you can describe the instrument. It has got a gap, carpaging on one by guillotine action. We press the handle, guillotine action, we break the bone in between. And the space between the it's a 3 millimeter one, that means it will make a 3 millimeter opening, 1 millimeter opening. So you can describe how it acts. Okay. Then you start talking about these, sir. If you don't know anything, sir, we make an opening in the entire lacrimal fossa, is removed and this opening is creating a communication. Okay. So this is how you take a calipers for castrometer, stainless steel, and you hold it like way. So this is a castrometer measurements. Measure the distance, procedures as well as surgery. Okay. So it has a graduated arc on one side, has 2 points, right? By moving it, okay, with the cycle, you can understand, you can know what that's something in millimeter. What are the indications? As per the specialty, you can give any amount of indication. Refractive surgery, white light. Corneal surgery, post graft junction sizing. Keratoplasty, you want size of the glaucoma to for your trabeculectomy flap size for 5 foot 8. In case of a UVA for congenital glaucoma, childhood corneal damage. Twin surgeries for this. Yes, retinal surgery. Intravitreal. Here they may start asking you, fake it for a surgery. Why this distance? Yes or no? So fix. You don't want to create a damage. So you're going more posterior. You don't want to come anteriorly and create a problem to the or the eyes. Okay, so you place 4 millimeters for taking patient, not go beyond. In case of pseudophakia, the lens is thicker now, thinner now. You want to come little anterior. You want to really. So 3.5 for pseudophakia, 4 millimeters. Phakia. What would normally. And they may start asking you about intravitreal image. There may be sometimes have a lot of anti-VEGFs lying on the table and they may start. But you should even know full name. Insulin, bevacizumab. So even this can create confusion for can mistake, confuse the actual names of the mechanisms of given invalid. Consider betadine creating this cause dangerous. Going direct. Don't take ASAP. Endophthalmitis happens in few hours, unlike cataract surgery, because you're directly not bacteria into the vitreous. Distance is very important. Direction is very important. First is directed to the and you should also try to create some kind of a valve effect. No, you pull the conjunctiva, inject and see the come. The serial entry and the conjunctival entry are not at the same. Okay. At the same time, at the end of the procedure, they'll ask you, do you do anything? It's again a trap. If you're giving anti-VEGFs, you will understand. They'll ask you at the end of injection, what do you see? Take too much of it. Take a high involvement. Doctors badly. So check the intraocular pressure, just give it to decompress. Another way is to just check is there a pre-injection vision is there or not. There's a central retinal artery occlusion. So if the pre-injection vision is there, like hand movements, of the finger. Very importantly, don't miss this. Always see the patient. You will never know who will impact because you're likely to. If you are taking care of these things, indicate that you are very practical done it or you've seen it being done and you are a safe ophthalmologist. Ask from all examiners what don't bundle up the safety of the. So have two examiners, three examiners, and three cases, two routine cases. That there are students who are voluntary on this. We will be kind of coordinating this. Yeah? So, one tip to the students is to exam. I mean, you basically present the case without a PowerPoint. Don't make a PowerPoint, but then there's no fun. So you present as if you're presenting a physical case without a PowerPoint, and the examiners can stop you, interrupt you, and can ask typical case. The whole difference is this is a dry run. They're going to ask you questions. They're also going to do it. Don't take it hard. Don't take it on basically what is your evaluation. Not trying to evaluate you. This is that can make more mistakes so that you can learn more. At the same time, all questions will be answered. Whatever we ask you, we are going to also we are going to give critical analysis of what can go wrong. So one person presenting can. At the same time, you not stick to that case itself. You also tell you the variation. Same case can form. In that case, what all can be different? How you must find your answers. Same time, how to actually briefly and tell you. These are examiners who are very commonly attending. They know exactly the student side. And we have picked up the examiners, the first person for senior examiners who know what really happens in next. Can get the guidance and the actual examiners things. Don't miss this opportunity for next. Cover all the possible. In case you need anything else, please you can ask during the session or you can hear a post in the group, but we will really come back with something. We will cover the OSCE, we will cover all the Viva things. From tomorrow, each time between the charts, like perimetry, refraction, whatever that is and the OSCE. And after all the cases are done, I have requested cover all the fundus cases in one mega session, one master class, so that can be an interactive session. You can clear all the doubts because everybody has a problem how to present a particular, describe a particular. What are the most likely questions are asked? You may have your own doubts about because not everybody is conversant with retina. So Dr. Guru Prasad will be the best to actually know the answers. Okay. Thanks for joining us here for the day one session. Thank you tomorrow at 7:30. Best of luck preparing. It is not only for the people who present, it is for everyone. Even though you are not presenting, please go to our school and be ready. Your mind to present it to yourself first, but you can be basically prepare notes to use. I really appreciate it. 20th to present. And that's all.
Madam, I will end the session.